In theater, we prepare for everything and anything. But when the monitor alarms change, when the rhythm becomes unstable, when the blood pressure drops rapidly, you don't panic. You move. Because in theater, training takes over. Welcome back to Nurse MamlieO, caring for you one health tip at a time. This is episode 5 and the last episode of the theater safety series. Today's topic is about one of the most intense situations inside the operating room, code blue. Code blue in this channel means a cardiac arrest. Situations inside theater will be called code blue. What really happens when a patient arrests on the operating table during surgery? You must be wondering. Arresting means things have changed for the worse and is critical. Let's step inside the operating theater. How does a team recognize a deteriorating patient? Electrocardiogram, which monitors the heart, will tell you their changes. The blood pressure changes. Oxygen levels in the blood, called the saturation, may drop. End tidal carbon dioxide and temperature will tell the story. Sometimes deterioration is sudden. A float line, a dangerous arrhythmia, a sudden drop in blood pressure. Oxygen saturation plummets. The anesthetist usually recognizes it fast and immediately calls it code blue and alerts everybody. The first minute is critical. Airway is assessed, ventilation is increased to 100%, oxygen is delivered, chest compressions are started if no pulse rate. There is no waiting for a crash team. The crash team is already present in theater because in theater there are several anesthetists and anesthetic nurses and everyone participates in resuscitation. So we do not rely on the resus team to come into theater. We do it ourselves. The anesthetist then leads. The surgeon stops operating. The scrub nurse maintains sterility where possible and moves the trolley away from the area. Everything becomes focused. And if the scrub nurse needs to come out of her scrub gown and leave her trolley sterile, she will come off the gown and help with the resuscitation. Then there is role clarity, which is under pressure at this stage. Everyone has a role. Anesthetics take care of the airway, drug administration, and rhythm interpretation. The surgeon controls the bleeding if there is, pauses the surgery if bleeding stops, and assists if needed. The scrub nurse protects the sterile field and anticipates instruments if surgery must continue. Circulating nurse brings the crash trolley, prepares a defibrillator, and documents the events. Clear communication is important. Short commands, no shouting. There is a stage where defibrillation and drugs are given. If shockable rhythm appears, charging to 200 joules, stand clear, shock delivered, immediately resume CPR. Drugs may include adrenaline, amiodarone, and atropine depending on the rhythm. Every 2 minutes, rhythm is reassessed. This is advanced life support in motion. Then theater arrests are quite different, and this is why. In theater we have advantages because patient is often intubated already. There is already IV access, maybe 2 cannulas, and monitoring has been continuous and equipment is within reach. This allows immediate intervention, but the stakes still extremely very high. Then with the return of this of spontaneous circulation. If circulation returns, blood pressure is established, oxygenation is maintained, blood gases are checked, and temperature is managed, then critical decision is made. Do we continue with the surgery or pack the patient and send to ITU? The decision will be team decision. And when it doesn't go as planned, not every cord blue ends up in recovery ward. And when that happens, the room becomes quiet because behind the training, there are human beings. Post-arrest, there will be debrief. After a cord blue, the team has a debrief where they discuss everything. What really went well? What should we improve on? Were drugs timely? Was communication clear? Because theater safety is about learning, not blaming. Code Blue in theater is intense, but it is structured, it is rehearsed, it is disciplined. The calm you see is not absence of fear. It is preparation meeting pressure. And that preparation saves lives. If this series has helped you understand theater safety better, please like, share, and subscribe to Nurse MamlieO, because when we understand systems, we protect patients. And in theater, safety is never accidental. It is intentional. Please watch full video of Operating Theater Safety Practice series on my channel and follow for more informative and educational videos. See you in the next video. This is just to share my experience after talking about Code Blue. Again, this channel, Code Blue, is cardiac arrest. So Code Blue in theaters, I have had experiences where we have done it, the resuscitation successfully, and where we have had losses. And it's usually very traumatizing to the team, especially if it's the first patient you're doing in the day. The morale just goes and you just feel like you cannot handle the remaining patients. It depends on what you're going to do for those patients, whether they're emergencies or elective cases. And where possible, another team can be put to continue with the list, although after losing a patient during surgery, the list is normally cancelled when it's elective, unless otherwise. So there is a case, a patient who comes to theater was just normally very normal, very healthy patient who just came for a minor surgery. But in the end, surgery was done. Patient was taken to recovery. This was ENT patient. Patient was taken to recovery. And from nowhere, patient even was talking. From nowhere, the patient arrested. And then the buzzers went off. It was in the evening at 5 o'clock. Some theaters had closed and people had left. So the team that operated on the patient, fortunately, was still there. And some anesthetists were still there. So everybody was rushing into the recovery to resuscitate this young man. Resuscitation took place, but we could not win. We did not win, and it was very sad to see relatives. I do not know what the postmortem said, but at that point, we did not see the reason why the person arrested, because in theater sometimes we don't follow this. There are also times when a woman just comes for cesarean section, and this also I have experienced. A woman comes for cesarean section, everything is done normally, but somehow you talk to them, you encourage them, the baby is delivered, and then bleeding starts. When bleeding starts profusely, then we call for help. We ask for blood. We did everything that we could have done that time. And the patient received so many units of blood. I do not want to say which type and which pack, because it's not necessary to mention that, because somebody who doesn't work in hospital, I want to make it simple. The person who doesn't work in hospital may not understand which pack is which. But the patient received 42 units of blood. which was really, really bad. Unfortunately, this patient was working in that hospital. It's not the hospital where I work now. Was working in pathology for that hospital, and that is where the blood was being picked up. So pathology guys started calling and finding out what is really happening to their staff. They knew was coming for cesarean section. Of course, they will see the name and the date of birth. They'll know that is their staff. Unfortunately, this patient went into crisis and was taken to ITU, and this patient passed on after 2 days. So sometimes resuscitation in theater helps, and the patient is transferred to ITU for further management. But there are times when resuscitation also is successful. They are resuscitated, they wake up, and they are actually extubated, but they are taken to HDU, high dependency unit, for further monitoring. And these are many cases where people have, especially when people were alert that this patient might complicate, there were signs that there's a possibility of something happening of the sort. So people are usually ready for all patients, but this one, there's more done in preparation for this patient. And it's always, there are losses that I don't know how the medical team come through with this, but for me, after experiencing this, it's very depressing. The whole week you will be imagining, what if, what did we do that wasn't right? Was the communication okay? Should we have asked for help, or what should we have done? But all I believe is that in theater, we are always one unit. We work together. There's everybody doing something, and we do our best for these patients. Most of it have been successful. And a patient who has been successfully extubated is monitored very closely, and they normally leave and go home. Thank you for giving me this time to explain this. There are many examples that I would have given, but I need to stop because the video may be long. In the future, I might just do a video of experiences of resuscitation in my nursing career. Thank you for watching.